The disclosure is I am not a great hernia surgeon. I just do once in a while. But essentially, being in a teaching institution, we do teach our students how to do the right kind of hernia, one correct way of doing it, safe approach that they can be having a reproducible hernia repair in all cases. I essentially do surgical oncology. Most of my work is cancer related. So that's a disclosure. I have nothing else to declare. No disease of the human body belonging to the province of surgeon requires in its treatment a greater combination of accurate anatomic knowledge with surgical skills than a hernia in all its varieties. As Sir Ashley Cooper how rightly said, even today we are discussing as to how to fix a hernia, which clearly means we don't still know what is the best way to do it, which is good news and bad news at the same time, because there's nothing like the only way to do it. So as they say, always is always wrong and never is never right. So we haven't yet found only one way to treat it. Well, a word about how did hernia surgery actually evolve, and a lot of you are very familiar with a lot of these stories about hernia fixation. Bandages by Mamun of Hammurabi are surgery forbidden by church till Renaissance, so for a long time it didn't happen at all. 1871, Marcy published a paper on herniorrhaphy. I don't have time, I would have shared this paper, very interesting paper as to how he thought hernia should be fixed. 1886, Bill Roth, first prosthetic repair, that was silver filigree, prosthesis was rejected. 1945, actually, I'm skipping Bassini for a particular reason. Schuldeis repair was quoted as the gold standard. He could produce tension-free herniorrhaphy, which was as good as, even today, as we consider to be the gold standard in its own way. 1956, Marlex was introduced by Usher, so it is not recent that the mesh came in, and they used nylon and terylene, actually, to be very fair. Terylene cloth was used for repair, but that was also rejected. Stopa and Rye principle of underlay unfastened mesh. And finally, of course, I can get down to the era of tension-free repair, which was in 1989. I'll just give a brief history so that we understand as to what have we done so far and where are we actually standing. Now, this was an interesting observation, and I remember even while training that my mentor insisting that if you use silk in the posterior wall, it will produce more fibrosis, which meant a bigger, a thicker wall, which meant a stronger wall. Actually, we know that was not true. McBurney's repair was essentially with more scar. So if you have more scar, the hernia would be healing stronger. But actually now we know by our experience over the years and also understanding of the whole concept that is hernia, that it's collagen type 1 that we are looking at, not collagen type 3. In a scar or a badly done scar, you can find collagen type 3 but not type 1. So it's an organized healing of fibers rather than a disorganized, which is what we need. So it's not a wall that we need, which is rigid. We need a flexible, mobile, and dynamic kind of a repair. So this was abandoned. Now this was an era. Therefore, I would generally divide it into two eras. One was 19th century to mid-20th century, which was an era of hernia repair under tension, where it was believed that tighter the better. And then came the era of tension-less or tension-free hernia repair. That was mid-20th century, of course, to the present. And each time that you talk about hernia today, all they say is no tension. A tense surgeon, tense repair, both cause damage to the outcome in hernia. We know tension leads to ischemic spots, which lead to bad kind of a fibrosis, a poor healing. Therefore, those concepts of darning, putting sutures across, putting them in Z fashion, they've all been abandoned for right reasons. Well, whether you're dealing with laparoscopic repair or anterior repair, end of the day you're fixing hernia, and that's the bottom line. If you're fixing hernia, it's basically a tale of two spaces, one that is above the inguinal ligament and the other one that is below the inguinal ligament. Actually, it's one space. You can look at it from above as well as from below. Essentially, it is, now we understand it's myobacterial orifice, and this is what has brought out the concept of a big mesh from behind, which can actually cover up both these orifices. Well, we very well know the lower orifice may not be so important. I was listening to Asuri's presentation on femoral hernias, but that's the part it can get covered. It's exactly the concept for the benefit of postgraduates. If you have a wall, you need to have some doors for people to get in and come out. So these are the spaces through which, say, suprainguinal part, the cord is coming out, and through the infrainguinal part, the femoral vessels come out. So they are the chinks in the armor. These are the weaker spots through which hernias happen, and we all know that. the arching fibers, the shutter mechanism, the obliquity of the canal, they all basically take care of this orifice, and that's essentially what we are doing even today. We are putting a mesh behind or in front, essentially to cover up this space. If you put a mesh from front, you're only covering the suprainguinal part. So one has an argument that you can go behind, so people started putting pre-peritoneally, and then came the concept of the proline hernia system, plug and patch system, or you have so many, you have as many repairs as hernia surgeons. So there is a logic in covering this up, because this is the weaker part of the entire inguinal canal and that region. Generally speaking, and this is not about which is better, because we don't know which is better, so therefore there is no point arguing for or against, except as it happens, it should be tailored to the surgeon, to the patient, to the center, to the situation, to whatever, and to the given day, whatever. Generally speaking, Lichtenstein, plug, PHS, true tissue repair, shoulder ice, Bassini, a grossly misunderstood operation. Bassini performed this surgery in 1878. He published his data based on 4 years with a recurrence rate of 20 to 21%. And what did he actually do was not what we see being done today as modified Bassini's repair. Bassini's repair was essentially taking conjoined tendon and the fascia transversalis onto the Popart ligament and suturing it as one. Actually was doing essentially what Scholdeis did later. But when Earl Scholdeis thought about it, he thought of tension-free repair. So he had four layers, double breasting, fresh tissue. And where did Bassini actually miss? One was the language. He could never publish in English. It was an Italian write-up initially. Later on, when it appeared in English, it was already too late in the day. Some other gentlemen had already done similar kind of surgeries. Well, having said that, modification of Bassini, you often find it written in many OT notes, modified Bassini. The modification is actually your own modification. Essentially, all that he did, even he made it a point that fascia transversalis is taken care of, but there was no concept of tension-free repair in that case. So they're all taken as one crumpled up bite, but they took care of it. Scholdeis learned out of it. He actually opened it up and he addressed the pre-peritoneal space, which is the only problem with Bassini. Otherwise, it's a fairly good repair. He just went behind and he took care of any other hernia which is redundant, may not happen. Like they claim, when you go from behind with the laparoscope, you're able to see a whole lot of hernias which may not be happening now but may happen later, on the contralateral side which may happen later. But the repair has evolved and we haven't yet heard the last word. And there's no reason why we should be talking more about it, because as of now, there is a concept of tension-free repair in whatever way you can, laparoscopic or open. The era of evidence-based medicine. Now, except God, everybody has to give evidence. So when you have to say something, it has to be supported by the evidence you have. And evidence is created by nobody else but humans, based on properly done research, trials and studies. So till such time that you have one from here, you have naturally got to follow the guidelines that exist. What is the current status of hernia repair world over? It could look like a slightly older data, but it's not changed much. I was last year in Michigan and there was this presentation on hernia in one of their MDTs. And this was discussed, some gentleman was doing robotic hernia surgery, and the discussion was as to, you're killing a mosquito with an AK-47, where if the mosquito flies, the individual dies. You may not fix the hernia, but the person may die. So that is where they were discussing, it should be cost effective, it should be reproducible, it should be cheap, it should be daycare, etc. They were also discussing it, so I just wanted to bring it in. Nearly 9 lakhs per, this data is very commonly, we all know about it. 20 to 30% only are fixed laparoscopically, which must have its own reasons. And in UK, NHS guidelines and NICE guidelines are that bilateral and recurrent hernias where it is recommended strongly. Other places, it has its advantages if it is done by somebody like Professor Lal sitting here, people who do it so very frequently with equally good outcome. But otherwise, it shouldn't be anybody's business to be doing laparoscopic hernia one day. The steep learning curve, which is not exactly linear, needs to be taken into account. There are advantages and disadvantages, and therefore one needs to be extremely careful when training residents to pass on a word. It's not right to say this is the only way to fix it. At the same time, one shouldn't say laparoscopic hernia repair is not good enough. It's good enough in the right hands. The statistics extended, nothing new. They are still the same percentage. Most hernias are fixed by the Lichtenstein or Scholdeis method all over the world. numbers fixed laparoscopically is less, which has its reasons. It's not that the procedure is not good. It's not been adopted as well as quickly as the other procedures laparoscopically. Well, we did a little bit to know it in 2012 when I was the secretary of the ASI. We conducted this survey to find out as to what surgeons would like to be done on themselves. It's an interesting observation. We sent many questions relating to various disorders. Hernia was one. And the observations were interesting in many, including sills, where the surgeons didn't want it on themselves, although they did suggest it to others. In conferences, they would talk loudly about it. Unilateral inguinal hernia majority, that is 70.1%, preferred open like tension-free mesh repair, and there was no confusion there. Bilateral inguinal hernia, almost half, that is 45.6%, did not were not rigid about it. They preferred laparoscopic repair, that too tap, not tap. About a third, that is in these cases, preferred open like tension-free mesh hernioplasty. That is just to let you know as to what surgeons would want on themselves. Is it either or something else? Now, whenever you find yourself on the side of the majority, it is time to pause and reflect. Many a time, especially youngsters, may actually be looking at all of us as to what do we do and what do we say, and they may get carried away by this looks the more recent one, this is the hipper one, let's take this. Well, that's where we need to guide them for or against it. Also, there is nothing more deceptive than an obvious fact. So there's nothing like this is obviously superior and this is obviously inferior. Be careful in analyzing and interpreting it. Now, we haven't yet hit the nail on the head. We've been hitting it left, right. So to say that this is the best way to do it is not correct. So what are we looking at? When we are looking at hernia fixation, what do we look at? A repair which is more popular, is it? More reliable, easy to learn and easy to teach, cost effective, reproducible even in the hands of an average surgeon. That is surgeon proof. I wouldn't like to use resident proof or fool proof or anything. It should be surgeon proof. Whosoever does it should produce the same result or at least similar result. Because the problem is, if you don't fix it, the hernia is not such a major disease mostly, and we shouldn't make it into one. If it can be fixed easily with a reasonable outcome, there's no point making the treatment worse than the disease. That's a general consensus. There is a lot of evidence for and against, so I'm just running through it. You must have been hearing it since yesterday. Current recommendation, routine use of mesh. These are things which are accepted. I went through the 2018 hernia guidelines where Dr. Chaube and people from all over the world, they were all involved. I just read through it, so I'll share with you. Routine use of mesh is mandatory. Need to counsel patients preoperatively. If you're doing open about the postoperative pain, groin pain, which is a problem that is what is attributed to the open repair. So we need to look at it that way. Evidence does not point to either one being superior, and you must be clear about it. Most of them are non-inferiority studies. That is, laparoscopic repair is as good, or Langston repair is good enough. Now, you then look at your own take-homes. Patient returns home next day or lives there forever, or the open patient returns earlier. We have all opens going in the next day or sometimes the same day. So it depends where you are and are you looking at it with the same lens. Surgeon preference and circumstantial influences will probably continue to dictate the approach. Just because the procedure can be done laparoscopically, it must be done laparoscopically is not correct, especially for the benefit of residents. Now, the European hernia trial group, all of you have been through this. It showed that recurrence rate is similar in both, and these are various studies where it's been shown that it could be almost the same. Now, in the majority of cases, TFR here is tension-free repair. And most centers, most primary hernias, it is a bailing out, standby in a failed lap, elderly poor performance status complications. Here there is no confusion. This is where patient not fit for GA, patient not fit for even a haircut. You would not be going for laparoscopic repair. So there are cases where you cannot do it at all. So those cases are not even in contention. As a matter of fact, this is not something that I am saying on my own. Laparoscopic repair is consumer driven, consumer sought, industry driven, elitist repair. Complications, whenever they happen, they're fatal. It's not like you can just walk out of it. For a select few, by a select few, That is, some people do this in some patients. Not suboptimal, but needs tailoring. You must not make a tool into a specialty. Laparoscopy is a tool, used rightly, it's a wonderful thing to use because you can actually get access to areas. When we go for laparoscopic APR, it has really made a difference for TME because you can get into the plane so beautifully. Vision is extraordinary. When people do robotic post-prostatectomy, they're able to put those bites so carefully and nicely because you can rotate. So use a tool effectively. It's not that you then build it up into a specialty and claim this is superior, because that's where the concept of elitist repair comes in. Minimally invasive, really, because this is where you need to look at carefully. You all done it, and it is hardly minimally invasive when you got in. It's about 10 centimeters of dissection, peritoneum reflected, and we have the triangles of doom and trapezoids of disasters, and mind you, for God's sake, it is only hernia. Well, done well, it shows the anatomy much better, you can put the mesh much better, but very often people get carried away because it is done by some select few who are really bright and very good, and they do it at a level when they've already done it beyond a point, they've been through everything. So watching somebody in the learning curve can actually help you understand that it's going to take that much longer. And the learning curve is not a linear curve, please, for God's sake, understand. It has its dips, it has its plateaus, it doesn't go straight up. You will be dipping, going up, dipping, going up, dipping. So it is proficiency curve rather than learning curve these days. So one has to be careful in accepting it as it happens. And we know that it is recommended for high volume center. Priming inguinal hernia laparoscopic repair can no longer be recommended. It's old statement, but I thought I'll use it. Very little has changed in this, which clearly shows we haven't moved that far. Repair of choice unless it is undertaken in an expert center in minimal access surgery, and somebody who can actually do it as well as anybody else doing open repair. Well, the recurrence rate for the first 200 repairs was 2.5%, but it decreased to 0.47%. So to be fair to people who do it well, they have only difficulty during the learning curve, and later on it can become a pretty good repair to do and very effective. This is Veterans Affairs Cooperative Study, which is quoted in US. Let me tell you, between me and all of you, we all know majority repairs, hernia repairs done in US are open leg tension tension-free mesh hernioplasties. In Canada, shoulder eyes, and also like Tenston. The reason is they have this, you need to have time for fixing hernias, and if they take that long in the learning curve, many other, the theatralists can have to wait. So it is very much dependent on which center you are. High volume center where people are getting trained into doing it well, it can well be taken as some kind of a reference point, but by and large, an average surgeon performing in the backwaters may not be very comfortable doing it. The authors concluded that opening while hernia is superior. Well, I'm not trying to, this is not my view, I'm just sharing with you some of the studies. Now, well, the complication rates being higher, but this is, I think, a fair call. Advocates of laparoscopic hernia believe that there is decreased post-operative pain, shorter recovery time. Nobody claims of a reduced recurrence rates. There are a few studies which show that, but by and large, it's matchable at best. And mind you, open leg tension mesh hernioplasty is resident proof, done under local anesthesia, day case surgery. Enables to inspect both the groins for a potential hernia that is missed clinically. That's like plugging all possible holes so that you don't get a hernia in future. Things like we've given up in, especially in breast surgery, the sentinel node biopsy positive doesn't mean you proceed with exudative dissection, because it is observed in many studies that those isolated tumor cells and micrometastasis never became macro. And also many DCIS were discovered in the postmortem. They found that they never had to become cancers. Patients died of something else. So maybe these hernias are never to manifest. Avoid the scarred operative site in recurrent hernias. Well, I'll skip this and I'll come quickly to the point where we have learned, with large samples we have learned that they're equally good, most places. Laparoscopic repair, therefore, when compared to open most randomized studies, marginal increased rate. I'm just giving you the summary of most trials. I'm not giving my recommendation. Marginal increased rate of recurrence, lengthier operations, steeper learning curve, advanced laparoscopic procedures, that is at least more than 250 repairs, cost is more, reduced post-operative pain and an earlier return to work when compared with the open repair. Bilateral orifices can be seen, Complications, whenever they happen, are fatal. You would not like to hear about bowel getting punctured, ilex getting damaged. I mean, that's not to call a hernia such a problem. And a word about the chronic groin pain. We have few studies from India, majority from outside. Only 2 to 4% adversely affected by this chronic groin pains. Maybe an exaggerated issue. Now, this is one paper that I had accepted when I was editor-in-chief of Indian Journal of Surgery for a reason, because it was an Indian study done in armed forces where they have a captive group of patients. They could have studied it much better. The incidence was less than, I think, 0.78, it was about 0.78%, which is negligible, maybe exaggerated, maybe it has been highlighted more than it needs to, and eventually it may not be as such a problem that you can recommend it for this reason. And when is enough proof enough? When do you want what to know? We all know it actually. Very often, even when you know, we don't want to accept it. People almost invariably arrive at their beliefs not on the basis of proof, but on the basis of what they find attractive. Otherwise, open repair, procedure under local anesthesia, resident-proof, shorter operating time, easy to learn and teach, comparable in terms of recurrence, cost-effective, complications relatively minor, post-op pain, return to work, etc. are subjective. These are subjective variables. We don't see patients going depending on that. We see most of them going. In fact, on the contrary, we have one theatre day for laparoscopy because that's all we can have. We have 4 tables where we manage cancer surgery more. So we find that they stay longer because naturally the surgeon is in the learning curve. Still is a bailing out procedure in a messed up lab. So we cannot write it off. It still needs to be there, and we need to learn both. Find in your setup as to what is right. As far as evidence is concerned, I don't suggest that this is the right way to look at it, but that is what happens most of the time. Get your facts first, then you can distort them as you please. A procedure not worth doing is not worth doing well. If somebody can do a particular procedure well, it should help also find the right kind of an indication. Just because somebody has graduated from laparoscopic cholecystectomy to the natural next extension, that is laparoscopic hernia, and if he can do it well, he will do it regardless. I don't think it's true in most surgeries that we do. Just because you can do it and you can do it well doesn't justify that you do it. The new technology sometimes merely succeeds in making the simple exquisitely complicated. And a fool with a tool is still a fool. Doesn't matter what surgery you do, it is how you use that tool. Laparoscope is a tool that you must learn to use. And can this tool be heavier than a thought? Certainly not. We need to use it judiciously. We shouldn't fall prey to the hammer and nail syndrome, where if you have hammer, everything is a nail. You should find the right training. You should have trained into doing it well. Please explain to the patient that I am in my learning curve. And let's see how many patients opt for surgery at that time. And also, make sure you are familiar with your learning curve and the outcome related to that. So need to be extremely, extremely cautiously done. Very often when we are rich, when we have lots of money, when our GDPs grow, like it's happened in this part of the world, we tend to be so rich that we cannot think. So on an average, most corporate setups, with nothing against them, are pushed by consumers to, we want a laparoscopic repair. Because with Dr. Google around, all of them know that laparoscopy can be done in all cases. And the crude form is, just now the reporter from the newspaper was asking me about the laser surgery. So I told him there's no laser surgery for hernia. If you push laser, then the problem is you wouldn't know where the smoke will come out from. So it is not understood the right way, and they feel that's one surgery which can be done all the time. The Roman Empire crumbled under the weight of its own prosperity. Beautiful book, Decline and Fall of the Roman Empire. It's a school book for a lot of us, and we find that Romans lived very rich and then they died because they were too rich to live. Finally, to conclude, ladies and gentlemen, future. Have we arrived? Nothing grows in isolation. Nobody can say one repair is better than the other. Naturally, you need to tailor it to this patient, to the surgeon, to the setup, to the training facilities, to whatever you have there. Robotics and the new world. I don't want to repeat what was spoken in the MDT at Michigan. You can't be killing mosquitoes with AK-47 just because you have AK-47. We have a concept of metalloproteases and petri dish solutions now, where you can actually grow these tissues, and it's quite possible that we'll find an answer by having the tissue growing there and actually building up a natural, mobile, dynamic wall. Something on the lines of Desada. I have just happened to visit his place, and that's quite a dynamic posterior wall. Balance between open and lap. You need to find the middle path of Buddha. You need to find out where it is useful. I'm sure in expert hands, it has those advantages. You can have a better look, but whether you want to look at that, that's important. But open would stay. The tailored approach would hopefully evolve. In the middle path, therefore, the opposite of a correct statement is a false statement. The opposite of a profound truth will be another profound truth. Both could be right, and you just need to find your answers. So don't get carried away by the fact that laparoscopic hernia would probably make you an elite surgeon who will operate on elite patients, and the evidence being somewhat equivocal, it is likely that surgeons or patients' preference will continue to dictate the approach employed in hernia repair for the foreseeable future. I don't know whether this would be true or not to say that we haven't yet arrived. We are still searching for an answer. Now, there is no time to look back, sit back, relax and think. We don't have time to change the wheels, push harder, Harry. We may not be, and I hope we are not, reinventing the wheel, because that would be a problem. Thank you very much for listening patiently.